Hello, everyone. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining us today, our clinical chief, Nick Smith, and our assistant medical director, Dr. Mike DePasquale. And in the history of the podcast, probably our most listened to episodes are the serial killer series. And the idea was, let's target the most common chief complaints and the killer diagnoses that you on the truck should always consider with chest pain, shortness of breath, abdominal pain, and so on. There's been an idea in my head for a while, and I know that Chief Smith agrees with this. We're going to see how it plays out. Let's continue that journey a bit and talk about what happens when that undifferentiated chest pain patient arrives to Dr. DePasquale and I in the emergency department. How does the approach of the emergency department and the emergency physician differ? How is it the same? What labs, what imaging tests, what's ordered, how is the workup initiated and continued? And no, you're not going to go to residency in emergency medicine over these episodes, but maybe get a peek behind the curtain at what happens after you drop that patient off. So when people call with chest pain, quick review, what things kill them emergently. And these are the chest pain serial killers. If you've listened to the podcast, surely if you're an MCHD listener and an MCHD medic, EMT, AMT, you better know this one. ACS, MI. PE, thoracic dissection, pneumothorax, pericardial tamponade. Those are the chest pain serial killers that we picked. Yes, you can be difficult and say there are other ones out there. We went with 5, and those are our 5. And listen back to the serial killer chest pain episode if you want a refresher. We're going to now move into the truck transition to the emergency department. Where do we start these patients? In the ED. And in route, you're always approaching those killer 5 diagnoses first. Vital signs are vital. Same for us too. 12 lead, first thing for us in the ED. If I can see yours, it's super helpful. I'm going to do a good exam, listen to the lungs, listen for murmurs. It's rare, but every now and again you hear one. Think about pulses. Pulses are very, very important to my exam, both quality and symmetry. JVD always gets brought up in all of our paramedic scenarios. Not super helpful for me in the emergency department. I'm going to ask about pain history too. When did it start? What were they doing? What makes it better or worse? All the PQRST things you ask in your oral scenarios here at MCHD, I'm going to ask in some form or fashion in the emergency department. And I'm going to want to know medical history and medications, recent hospitalizations, cardiac risk factors and PE risk factors are going to be very important in there. We're going to target those as we talk through those. But honestly, my start in the ED is pretty similar to where you start on the truck, Chief Smith.
Yeah, so first of all, thank you both for participating in this. I think this is an extremely valuable approach. I know a lot of times when we drop patients as medics off in the ED, there's sort of a mystery behind the curtain, if you will. We see the initial interaction with the nursing staff, and of course we're quick to get back in service and move on. So I think there's a lot of corollaries here and other things that are just interesting to learn and hopefully can help us be more efficient as medics when we transition the patient to you guys in the ED. So with that, Dr. DePasquale, I will pick on you first. Can you talk about the first serial killer with ACS or MI? What's your approach in the ED? So we bring you that patient. What are you doing? What are your steps?
Okay, so we think this chest pain is ACS, right? So I think that the medics probably do the exact same first 10 minutes of every ER doc, right? And that's kind of the point of EMS, right? It's the first 10 minutes of all these diagnoses, right? And then we kind of move into the ER and do the remainder. And so if we think ACS is on the table, the first obvious big decision point is STEMI or not STEMI, right? Or you could, I mean, in the more recent talkings, we've been talking about the occlusion MI or the OME, but not everyone is on board with that yet. So the big one, the first decision truly is STEMI or not, right? Because if someone's coming in and they have STEMI on their EKG, it's pretty much a done deal about what's going on. Now, I will say the only caveat to that is it has to make sense, right? All these have to make sense based on presentation. If the EKG is screaming STEMI, but this is a young person who doesn't look like they're in any distress at all and vitals are fine, well then maybe it's not. Maybe we're missing something else. Maybe the EKG machine is wrong. The interpretation on the machine is not always 100% right. And so most of the time I disregard what it says. And this is why we teach the medics too, to just always read and interpret your own EKGs. But let's say we're talking about, 60-year-old gentleman with chest pain and a little bit of sweating and all that. If it's STEMI, that's a STEMI, right? We're calling the cardiology, we're calling the cath lab, we're pulling the trigger, we're activating. So what happens next? We give aspirin, same as you guys. If they haven't already had aspirin, we're giving aspirin, right? We do a couple of other things. They get heparin loaded for anticoagulation, plus minus some antiplatelet medications that can sometimes be cardiologist dependent on which one they want, if they want one at all. I will tell you that the very next step after ACS STEMI is they get therapy pads put on, because guess what? These people go into cardiac arrest. There's a non-negligible number of people, somewhere in the range of 10-ish% of people, who go into ventricular tachycardia and subsequent VF while having a STEMI. And I think if you've been a medic for any amount of time, you've seen this. I've definitely seen this in the ER, and it should be no surprise to anybody. They went into VF. We need to shock them. But anyway, moving away from that, the next branch point, right? So if it's not STEMI, is okay, well, what are we going to do now? So everyone, I'm sure, is familiar with the troponin, right? So we're going to get some lab work. We're going to get a troponin. If you're not familiar, troponin is a protein that lives in the heart. It should only live in the heart. If it's not in the heart and the heart is leaking it, it'll wind up in your blood. So we test your blood for it. And so if we can detect blood levels of troponin, that means it's coming from the heart. And really what we need to see is how much of it is there. There is some acceptable small amount, and there are different reasons why troponin winds up elevating in the blood. If you go run a marathon, at the conclusion of that marathon, you will have a troponin elevation. Doesn't mean you're having a heart attack. It means that your heart was just working. If someone comes in rapid AFib or SVT at 200, and we convert them and that's all fixed, and then you check a troponin, guess what? It's going to be elevated because the heart was just going at 200 a minute. It doesn't mean they're having an MI. It all has to matter in terms of context, which is why the big story always matters. So remember, whenever anyone hands you a 12-lead EKG, your very next question is, what's the story? Because you can't interpret the EKG fully without knowing, is this a 5-year-old? Is this a 50-year-old? Is this a 90-year-old? And what are they coming in with? So we check troponins more than once. The reason that we do that is because if you check too early, you may miss it. So if someone's coming with chest pain they've been having for 30 minutes, the rise in serum troponin may not happen for an hour afterwards. So if you check too soon, and I have firsthand seen this, first troponin check using the new sensitivity ones was 50, which is generally normal. Next one was 5,000. That guy had a great story, and I wasn't surprised. I was like, well, there it is, right? Now, the EKG didn't have any changes, but he was having the troponin changes that were consistent with serious ACS, and he was admitted subsequently. The next thing we think about while we're waiting for the labs to come back is kind of pain control. We do the same nitroglycerin, right? As long as the blood pressure is appropriate and the patient is a good candidate for it, ask about ED medications and that sort of thing. If they're really super uncomfortable, fentanyl or morphine, just the regular pain control stuff that we do. Oxygen, again, only if they're hypoxic, not as like a standard thing. We're not doing MONA anymore. Those days are over. And then, so say they had a decent story and the troponins are both negative. Obviously, we got a chest x-ray and that looks okay. We won't talk about kind of the other differentials. That's for later. But really just focusing on the ACS stuff. The next question is what now, right? So they had chest pain. The workup looks okay. Now what do we do? And a lot of this is just kind of risk stratification. Does this patient have a history of 3 prior heart attacks and this one felt similar and their troponin's just not elevated today and their EKG looks okay? That person's pretty high risk, and we probably would keep them at least for overnight monitoring, if not to have them get a cardiac stress test or at least check an echocardiogram while they're inpatient. Every system is different, I'll tell you. Some places have very robust outpatient systems where you can have really close follow-up with cardiology in 1 to 2 days for patients who that's appropriate for, and that's great. Those people can discharge with good instructions to follow up with cardiology tomorrow or the next day, or they'll come into the hospital. We use a lot of decision tools. You've probably heard of the heart score. That's a big one. And honestly, all that is a combination of what their troponin was, what their EKG looks like, how old they are, and what their risk factors are, which is literally what I just said, right? And it's just put into a standardized format so we can get a number at the end, and we can all feel comfortable or not based on what that number is on their heart score as to whether they need to come in for observation or they can go home and follow up with their cardiologist outpatient. That's the biggest, I think, delineating factor is when they go home is just kind of the totality of the picture. Just because someone has 2 negative troponins doesn't mean they are completely fine to go home based on their story. They may very well be, but sometimes they're not.
Excellent. So what I'm hearing a lot from the different points that you relayed is exactly how important that story is, or potentially how important that story could be with collection from the medic in the field and bringing that to you, and the living factors and any sort of medical evidentiary findings that they have. You really do take that into account into what you're going to do for the ultimate outcome of the patient.
That's a big piece. For anyone who doesn't think that the hospital cares about your report, I would push back on that because it matters tremendously. If someone had a brief cardiac event at home that has since resolved by the time they've made it to us in the emergency department, but you tell me, boy, when we got there, he looked terrible, he was pale, he was diaphoretic, he was gripping his chest, and when we see him now, he's just sitting there going, yeah, I was having some chest pain earlier, but I feel better. That changes the story completely. And the patient's not going to offer up, hey doc, I was pale and diaphoretic. The medics are, and that changes it. That's a done deal for me. If someone was pale and diaphoretic at home, that's a huge difference than just I had chest pain that's better.
That's a great take-home point for us. Absolutely.
Even in the formalized scoring systems, heart score probably gets the most press, but there are other versions. EDACS is another one that's very common. And one of the problems with the heart score is that there's really nothing specific for diaphoresis that's specifically targeted in the EDACS score. And for me, that's a medic gimme. If the patient was drenched in sweat, I am done. Troponin negative, EKG negative. That's a patient that needs to be in the hospital. So I think that's where your history from the truck can absolutely save us, and more importantly, save the patient.
Excellent. Well, Dr. Patrick, what about a PE? What about a pulmonary embolus when you're differentiating that as the second serial killer? What does that look like for you?
I'll just start off by saying we think about PE
a lot.
Orders of magnitude more than we see PE. And so when we get to the end of the episode, what you're going to find out is the serial killers of chest pain are all pretty darn rare. Most chest pain ends up being undifferentiated. But with PE, we start with the same places y'all start. We start with the vitals. We start with high-risk history pieces, just like we do in EMS. The PERC rule, one of the PERC tool is one of the more commonly used tools that classifies, again, risk stratification for pulmonary emboli as opposed to ACS. And it helps us decide who we have to test for. In other words, if all of these boxes are checked, we can confidently say it's not a PE, upwards of 98, 90, 99% accuracy. So if they're less than 50, if they have normal heart rate, normal sats, greater than 95%, if they don't have leg swelling, if they don't have hemoptysis, no recent surgery or trauma, no prior DVT or PE, and no exogenous hormone use, birth control or hormone replacement therapy, those folks don't even have to be tested. So no blood work, no CT scan, very acceptable to document in your chart that the patient is PERC tool negative, PE unlikely, and move on into your other differential diagnoses and your other chest x-ray and ACS and EKG interpretations. Now, if you are higher risk, a little bit, medics often ask me, Doc, what's this D-dimer thing? Do we need to get a D-dimer? And Lord, if we had hours, we could discuss the nuances and the intricacies in this test. And it's one of my least favorite labs in all of emergency medicine because it's, in my opinion, consistently misused and misapplied. So I'll try to do this without any negative attitude here. But D-dimer is a byproduct of clotting. So if it's elevated and we see D-dimer in the bloodstream, it suggests that there's possible abnormal clotting going on, that you've got a deep vein thrombosis or a pulmonary embolus. But it's also an inflammatory marker. So it can be elevated for lots of other reasons that are non-PE or DVT related. So when you order the test, the idea is if it is negative, you've ruled out pulmonary embolus and or DVT. If it's positive, then you're really back to square one. It doesn't mean you're necessarily any more likely to have a PE or DVT. It just means you've not ruled it out successfully. I'm not going to get into the mud and the muck there. There's a lot more to it. Bottom line is, if you're a low to moderate risk patient and let's say that you're 55, we can't use the PERC tool in a 55-year-old patient. The age is too high. So maybe the heart rate is normal and SATs are normal and you're on hormone replacement therapy. So you're 55 and you've got another risk factor in the fact that you're on HRT. But man, she looks really good. I don't want to subject this person to a CT angiogram for PE. Let's just try a D-dimer first. That's kind of the textbook patient that we order that lab work on. If it's negative, she goes home. If it's positive, we proceed on to CT angiography. And that is the gold standard for PE, is a CT angiogram of the chest. Again, we think about it a lot more than we find it. PEs can present in wildly variable ways. Folks can have astoundingly normal vital signs. So they are something that we're all afraid of in the emergency department, probably more so than we have to be. But everyone out there that's practiced for any extended period of time has a story of a patient with a massive saddle embolus and very normal vital signs and very vague symptoms, and they're not an extremis. And so we all get scared by that. If we find the PE, so now we've checked the D-dimer in Our Lady, it was positive, we proceeded on to a CTA, it was positive, then we have to think about how big that PE is and how much hemodynamic compromise it is or isn't causing. There's some gaining traction belief, and I believe this extends back to a lot of the folks that taught me, is we're, with our increased sensitivity of our imaging, we're finding a lot of really small PEs. And one of my mentors and favorite teachers said, we don't need to find these. That's your lungs doing their job. That's your lungs protecting the brain. And so smaller and extremely small subsegmental PEs can now even be treated as an outpatient, at least in some spots. I'm not sure if I'm quite there yet, because that goes against the way that I was trained pretty 180 degrees. But they also are very, very stable. And so that's a movement. If they're larger and we have right heart strain, which is what we look for in hemodynamic compromise, because if you think about where that pulmonary embolus is in the pulmonary artery, if it's huge, then the right heart can't overcome that. So we get right heart strain, loss of preload, we get elevated BNP, which is a sign of volume overload in most patients, but in a PE patient, it's a sign that the right heart's under strain. It doesn't necessarily reflect volume. Sometimes troponin can elevate. Why? Because your heart's trying to pump against a big clogged pulmonary artery. We look for signs on echocardiogram, either bedside by the emergency physician or formally. And really, most importantly, is the patient's vital signs and how do they look. Are they tachypnic, tachycardic, hypotensive, hypoxic? And the sicker they get, the more invasive we have to be. And right now the question is, yes, they all get anticoagulated very quickly. That's very important, some form or fashion. Why? We don't want that clot to get bigger. But there are other methods now, just like with large vessel occlusion strokes. We have endovascular therapies to go pluck the clots out in the brain. We can do that in the pulmonary vasculature as well. Which patients get anticoagulation, which patients get endovascular retrieval, which patients get thrombolysis, that's not a question that's easily answered right now. But the more severe those pulmonary emboli are and the more hemodynamic compromise we have, the more aggressive we are. But they're going to get some combination of anticoagulation plus or minus endovascular retrieval and thrombolysis. Remember, anticoagulation stops clots from getting bigger. Thrombolysis, like TNK for strokes, actually breaks down the clots, or we go pluck them out. And the balance there depends on the patient's risk factors, what medications they're on, and how unstable they are.
So again, not to beat a dead horse with this, but there is a lot of information that can be taken from the pre-hospital side, bringing them into the ED that can kind of help speed up your decision with story, vital signs, presentation, et cetera, so that you're not waiting 50 hours for a D-dimer, as it sounds like.
Yeah, I mean, those vital signs that go into your PERC decision tool, those can come from EMS, and any abnormality in those vital signs, oftentimes the patient may come back to the room and have a heart rate of 80. If it was 110 in triage or 120 for EMS, they actually failed the PERC tool. And that's one we've all been guilty. I know I've been guilty of missing. A big swollen leg in a patient that's wearing pants in the wintertime. I may have gotten my 7th patient on the EMS stretcher, and I'm running to the next room that needs to be intubated, and the medic stops me and says, hey, her leg's really swollen, and she's on insert birth control pill. And so that I've had that happen, and it's absolutely positively. I've turned around, gone to the computer, ordered the CT angiogram, said, let's just cut to the chase and get the answer, versus how long is it going to take me to get there in a real life emergency department setting? Who knows? So very much the history, the exam, the thought that, hey, this could be a PE and it's not run-of-the-mill chest pain, because to go to Dr. DePasquale's ACS, so often chest pain is cardiac. And what we'll find in some of these other killers, it's not cardiac, it's pulmonary, or it's vascular, or it's a combination of those things. And so, very, very helpful.
Awesome. Well, Dr. DePasquale, let's move on to the third one here. Let's talk about aortic dissection.
Nobody wants to talk about aortic dissection.
Well, I'd like to hear about it, though. So, aortic dissection as our number 3 serial killer here. Can you talk about that a little bit, and sort of your side, your receptive side, differentiation, all of that goes into it for your favorite topic here?
Yeah, I think everybody hates these because it just always sits there in the back of your mind, and you're like, is it a dissection? I don't know. I think the theme of the day here today is that the story is what matters a lot, right? And hopefully these patients can tell you the story, because these progress rapidly, and I think up to about 25% of them die before they even make it to us, because these can be sudden and abrupt. And they can deteriorate very rapidly for EMS. So honestly, if that's what's going to happen, it's probably going to happen in front of EMS, because people are going to call and they're going to say, my chest and back hurt, classically. EMS is going to get there. They might look okay at first and then rapidly look worse, and then perhaps they die before they even make it to the hospital. The history is a big one here. Classically, this is someone who has chest pain. It's described as a tearing sensation. It radiates to the back. Usually it can be a younger person. Doesn't always have to be an older person. This is not what you have in your mind about an old guy having ACS, or this is like a 30-year-old healthy person, or maybe it's a weightlifter who lifts something super heavy and then they have this pain in their back. Like, those are all kind of the classic stories. Those are easier because you're like, yeah, let's scan that person, right? But the ones that aren't as easy are the ones that are vague, right? I'm having this chest pain. Not everyone has it going to their back, right? How far down is the dissection? Does it extend from the top all the way to the bottom? So are they having lower back pain? Are they having abdominal pain? Or is it a type A? Is it just the top part, right? So now they're having arm pain, or they're having a lot of chest pain because the coronaries are dissecting, right? There's a lot of stuff that can dissect. And so the workup starts the same really as every other chest pain. Or you're going to get the regular kind of ACS style stuff too. And what Dr. Patrick said about getting pulses is a big point here too. Not only the presence of pulses, but their quality, right? Because if they're having like a big dissection down to the legs and their arm pulses are fine, but their leg pulses are terrible, or they have leg pain. Sometimes a teaching on this is chest pain and, right? Chest pain and my leg hurts, chest pain and I have a weak pulse in my leg. Definitely clues you into maybe there's something vascular going on here. That's easier, right? If you can't feel a pulse, that there may be something vascular going on. And everything that I just said is great and helps towards the diagnosis, but sometimes people present without any of that and they just have chest pain. And so this is often missed. I mean, this is not, it's not a common diagnosis. It's something that we all think about a lot because it's not hard to miss this one. So the way to diagnose this is the gold standard is CT angiogram of the chest to look at the aorta. These patients with chest pain are going to get chest x-rays. You may have some widening of the mediastinum that would be present because the dissection is causing widening of the vasculature there, and that may clue you in, especially if you thought about this might be somebody with dissection anyway, but that doesn't have to be there, and that doesn't sell it by any stretch. You have to get the CTA. But I will say if they rapidly decline and all you have is that x-ray to go off of, I'm still making the call, right? You can do ultrasound. You can try to get some sort of ultrasound view of the heart to look at the aorta well. And if it's visible there and you can see it, then that may also make the diagnosis. But if the patient's awake, no one's going to surgery without the CTA. So you just got to get the CTA done. And to be honest with you, with high index of suspicion on these patients, I'll pick up the phone and call CT and say, this patient goes next. Send this person next. Unless you have something else equally as horrible going on, like this patient needs to be scanned next, please, thank you. So I mentioned type A and type B. There's two big types. Type A is basically, it starts at the base of the aorta and extends up towards the arch. That's managed surgically. That needs to be fixed surgically. Again, as we know, the coronary arteries branch off of the aorta at the very beginning, so much so at the very beginning that when the valves are open, they're not getting blood flow, and only in diastole do the coronaries get blood flow. But if there is dissection there, these patients can have what looks like STEMI on EKG. And I have personally seen this where someone came in with chest pain and we all said, we found the diagnosis, it's a STEMI, because look at this EKG. They take him to the cath lab and they're like, actually, it was a dissection that dissected backwards into the coronaries. And so, yes, the heart wasn't getting enough perfusion, but not because of a clot, because of a dissection. And then type B is a descending, right? So from the arch down, can go all the way down. That is usually managed medically. The main goal for all of these, though, is blood pressure and heart rate control. And generally, most people are reaching for esmolol. I know I am. I'm sure, Dr. Patrick, are you doing that as well?
Usually esmolol with cardine, often.
Sure, absolutely.
Multiple medications. The idea, again, is to keep heart rate down, to keep pressure down. If you're a physicist out there, high heart rate, high blood pressure leads to higher shearing forces. I'm not a physicist.
Right.
I just listen to the fact that usually you want the heart rate below 60, even below 50, and that pressure often below 120 or even lower.
Mm-hmm. And I'll go lower with the blood pressure within reason to get the heart rate down, because the less amount of force and the less amount of times we're doing that every minute is better, I think. And the reason we use esmolol and other drips like nicardipine is because they're easily titratable and they don't last long. So when you can raise them or lower them and get the desired effect kind of right away. This is not the person that you're giving a labetalol push to. This is someone that needs to be on drips and very tightly control of their blood pressure.
Now, while we're on the subject of blood pressure and monitoring blood pressures, sort of the classical teaching that we have in medic school with our limited diagnostic repertoires, we talk about blood pressures and variations on one side versus the other. How much weight do you put into that? And is that something that if we came in with, continuing the theme, a story here and said, hey, this is one of our findings, is that something that you take a lot of consideration into? Are you really looking for pulse differentiation? What does that look like when you guys hear that?
I'll take that and say yes and yes, but some consideration, because you can have an aortic dissection with equal pressures in both arms. So it's not a rule out test, but if I get a drastic difference between the left and the right and the story's good, then I'm going to be even quicker to call CT. So I'm not putting all my eggs in that basket, but it's part of my workup. I'll let you.
Yeah, like what he said is important, is the story. Like we keep talking about the story, because I've had plenty of medics who are like, oh, their arm blood pressures are different, but they don't have a good story at all. And I'm like, oh, okay, thank you, right? And I appreciate that, and we'll check too, but that really wasn't even on the radar. They were here for something totally different. Or they're like, they have belly pain and their arm pressures are different. And I'm like, well, if it was in their belly, we'd be doing legs versus arms, right? So if the story fits, we take that into consideration for sure. I don't think there's anything wrong with doing it. It certainly doesn't add any delay to take an extra blood pressure, and note that these are wildly different, and it could definitely help the thought process along, especially in a busy department where the physician is seeing a lot of people, and you say, this guy's got chest pain and he's got a blood pressure in the right arm that's 50 points higher than the left arm, or vice versa, right? Right.
Well, Dr. Patrick, let's shift to our next one here. Let's talk about pneumothorax.
A little simpler. I mean, PE and the diagnosis of PE and the management of PE, man, emergency physicians can go all night long on that one, and no one will agree. Thoracic dissection scares everybody to death. You see one thoracic dissection for every 600 ACS patients. Spontaneous pneumo, a little more my speed.
Yeah.
Just not quite as complex. Point of care ultrasound is all the rage for a diagnosis of spontaneous pneumo, but I'll be honest with you, I have x-ray machines around the corner in my departments where I work, and so do I use point of care ultrasound in the trauma patients? Yes. In a spontaneous pneumo, that most of those are going to be more stable. They don't have open tib fibs and brain injuries and lacerations and blood loss. Most of the time, I'm still relying on a chest x-ray in those patients. They used to all get chest tubes, all big chest tubes, big 36-inch chest tubes. What we found over the last 15 years is that not as many of them even need chest tubes at all, and the ones that do can tolerate a much, much smaller French catheters than I was used to training and putting in. So I've definitely amended my practice to these folks, and even some upwards of 20-25% collapse. And how we grade collapse is really pretty simple. You look at the side that's not affected and how much is black on the side that is. That's the percent pneumo. So you just kind of estimate. That's about 25% down. And you see lung markings all the way out to the chest wall in the non-affected lung, and you will see the lung lining and the edge of the pleura very faintly, and then you'll see black in the gap between the lung and the chest wall. So, 25% or so, oftentimes those can get observed now. They don't have to get a chest tube at all. And as someone who's put in a few chest tubes, I know Dr. DePasquale can echo this. Not a pleasant thing for patients.
No.
Not something you want to really do just for the heck of it. So serial chest x-rays and pain control, chest tubes for the ones that are 20-25% or bigger. There's a lot of teaching out there that putting these folks on 100% oxygen causes the pneumo to resolve quicker. That's probably not true and old and dated. Not a whole lot of evidence for that. When you do put a chest tube in, what are you doing? You're putting a tube in the space between the visceral and the parietal pleura that now has air that shouldn't have air. And when you suction that air out, now the visceral and parietal pleura are forced back together, and the hole that is there, most of the time those pneumothoraces in the spontaneous non-traumatic situations are blebs, oftentimes in asthmatics and COPD patients. You're allowing that to heal because there's no pressure anymore that's been suctioned out. And so what happens in the hospital on day 1, day 2, day 3 is that suction is slowly turned down, chest x-rays are taken over time, and the pneumothorax is watched, or at least the side that was affected is watched to make sure that pneumothorax doesn't reoccur. And even small ones at times can go home, managed in clinic. They all don't have to be admitted. There's some Heimlich valve type devices that can be applied, and those patients can actually manage those at home. That goes back to Dr. DePasquale's point in the chest pain part of the discussion. Is a lot of the management of many of these diseases depends on your hospital structure and how quickly those folks can get in to be seen by a pulmonologist. Most non-traumatic pneumothoraces are managed by medicine, by pulmonary, as opposed to the traumatic pneumothoraces that are managed by the trauma service.
Now, would you say here at MCHD we have our indications for initiating a needle decompression where we talk about hypoxic presentation with hypotension, with, I think on our part, a good story as well. Would you say that's pretty well mirrored in your emergency department practice?
Yeah, I'm not going to needle decompress anyone in the ED unless they're in shock and I'm just temporizing until I can get my finger in their chest. And most of the time I can get my finger in just about as quickly as I can get a needle in. When we're talking about the serial killer chest pains, remember these are the non-trauma, the medical events. And so I'm not going to say never, but tension physiology in a spontaneous event is quite a bit more rare. And so I'm just not in as big a rush in this situation. Most of these patients aren't in hemodynamic collapse. So I'm going to take time. I'm going to get a good x-ray view. Sometimes you get CTs on these folks for whatever reason. You have even better visualization of the pathology. But I'm not needling these medical spontaneous pneumos. I don't know that I've ever done that. I can't say definitively, but if I've done it, it's not been very much because they're just more stable. They're not going to have that IVC collapse and the right heart collapse and the tension physiology that trauma is.
Makes a lot of sense.
Yeah, that's the big take home. I think that the medics sometimes, and I've heard this question too, is, how come we're not needling these pneumothoraces? Well, because they're not tension. There's a big difference between someone with a pneumo. Okay, we have time. Like Dr. Patrick just said, they could probably go home depending on how big it is, versus a tension pneumo, which needs to be addressed right now, right? That's the big one, right? If you have somebody who is a tension pneumo, then yeah, you should needle that person or put your finger in them, like that. But without tension, leave it be.
And if you needle a spontaneous pneumothorax, you've generally bought them a chest tube. So
Right.
That's the other piece of the puzzle, is that they may not be able to go home. They may get observed, but if you put a 14 or a 16 gauge in their mid-axillary line, 4th, 5th space, anterior axillary line, then they're most of the time, I won't say always, but most of the time going to end up with a chest tube. So some of those could be in situations where they wouldn't have gotten that chest tube without the needle thoracostomy. So it can be patient detrimental.
That's a good clarification point about the tension pneumothorax, being able to differentiate that. All right, Dr. DePasquale, kicking it back to you. Let's talk pericardial tamponade.
That's right, tamponade. That's one of those T's and H's and T's, right? We're all thinking about whenever someone's in cardiac arrest, right? Are you thinking about that, Chief Smith?
Yes.
He gets the test answers right, yes. This is probably the rarest of all 5, honestly.
Yeah. Yeah, so if you're thinking tamponade, there's probably, again, some history there as to why you might think that, right? Either the patient has a known history of pericardial effusion, or they have a history of being wildly fluid overloaded, or someone has said something, right? Or on physical exam, you hear muffled heart sounds, or some reason you're thinking that way. Now, generally, if they have tamponade, they're doing poorly, right? This patient is likely unstable. Otherwise, they wouldn't be in tamponade. They would just have an effusion, right? Tamponade is where, like anything else you tamponade by pressing on it, the heart is being tamponaded, right? And so that's not good. And so this is kind of easily seen in the emergency department now with point-of-care ultrasound. Recently, I had a case where this was a consideration, and the patient had just actually come out of cardiac arrest from EMS. And we put the probe right on the chest once we got pulses back, and there was a humongous effusion with basically you could see in the diastole phase the right heart was getting squished, and that shouldn't happen. And I'm like, wow, I think he's in tamponade. And so that's this one rare patient where you got to get after it, right? That's not going to happen in the EMS setting. And if you listen to some people who have been doing it long enough, they tell me that they used to do it in the EMS setting. But that involves, right, a needle across the chest or under the subxiphoid spot into the pericardium to physically just drain off that fluid. And once you do that, the hope then being that the heart's not really the issue. It'll pump. It just wasn't allowed to. And once you alleviate that, it'll start pumping again, right? The pericardial centesis doesn't have to happen in the ER, right? It can happen by cardiology if the patient isn't in such extremis. If there's just a large effusion there, eventually it'll need to be handled, and that'll either happen by, pericardial centesis, or they can have what's called cardiac window, where CT surgery just goes in, and as it sounds, they just make a little hole and let it drain out and make this little window so that the fluid is allowed to drain. But the other things to think about there are why that's happened, right? And so did they have a small leak? Is there a wall blowout from a recent MI or something like that? Is it blood or is it fluid? Kind of what fluid do you get from that? Are they on anticoagulation? Do you need to reverse that? I mean, these patients are all talking about disposition. These patients obviously are all being admitted and are at risk of doing much worse, so they need to be kept an eye on, and this may or may not need to happen. Not everybody will get the pericardial centesis. Sometimes you'll just watch and wait. If it's not super significant, some of these are caught on x-ray versus ultrasound. Some of the, obviously they'll be seen on CT scan. You'll see a big amount of fluid around the heart. So there's a couple different ways to look at it, but in the moment, in the emergency department, if there's any kind of consideration, or to be honest with you, if you have undifferentiated shock and you look across the chest at the heart, this may very well be what's there.
And I would say from an H's and T's standpoint, what's progressed more in our practice than the H's and T's of PEA is really the H and the T's of undifferentiated shock. Mm-hmm. And using the ultrasound in the shock patient who you're unsure, clearly not anaphylaxis, not all the signs of sepsis, no real story for blood loss. What's going on here? Why is this patient not responding to fluid bolus and potentially to vasopressors? I believe even old folks like me deserve to put the ultrasound on the heart and look for tamponade being one of the ones that you can catch there, along with other things, right heart strain, potentially pointing it towards a PE. There's a lot of information that you can get there.
Now, up to this point, we've talked purely about the serial killers. But Dr. Patrick, what happens when it's all negative?
That's almost every time, y'all. That's the news flash. We saved the best for last. most of the time, it's not going to be any of these 5. And yes, the history is absolutely vital. Vital signs are vital. The EMS report is vital. We're going to do labs, x-rays, CT scans, decision rule scores, and very often the chest pain patients, even the ones y'all are really worried about and the ones that I'm worried about when they cross the threshold, end up having all of these tests in some form or variation turn up negative. So what happens? It depends on their age. Depends on their risk factors. It depends on social factors, family support, all of those things. I tend to divide them oftentimes if they are risky for pulmonary or cardiac issues. Those often get admitted for further evaluation, consideration of stress testing and cardiac catheterization and other things. Too much for this episode. Young folks, I try to divide into, is it a GI source or an inflammatory source, being the most common non-emergent chest pain diagnoses, things like gastritis and peptic ulcer disease versus pleuritic pain and costochondritis and some of those other things that we don't have clear labs or imaging for. And so if they're an inflammatory situation, I'm leaning towards NSAIDs. If they are GI, I'm thinking about things like histamine 2 receptor blockers like Pepcid, and really close PCB follow-up in those situations, because chest pain is still chest pain. Even when they're young, there's always that thought in the back of your head that chest pain can always be something underneath the surface. It can always be bad. That's why how they look and the history and the subjective is really as much or more important than the objective. And again, this is much more common than the serial killers. We are looking for needles in the haystack with serial killers, and the haystack is all of the non-emergent, non-specific chest pain that we see. So we have to rely on knowing what it's not as opposed to what it is in the emergency department. And I say that all day, every shift. Mm-hmm. You came in today, we did all of these things, and we ruled out all of these bad things. And I go down the list and look at folks and say, which leads me to and leaves me with the fact that I don't know exactly what it is, which is why you have to come back if it gets worse, follow up with your PCP, see how our treatment progresses. So hopefully that gives you a little window into our world, takes the serial killers to the next 30 minutes. That's what happens in that 30 minutes to an hour after those chest pain patients arrive in the emergency department. So let's take it home. We're a little bit over our normal time, but I believe this is a good discussion and worthwhile kind of taking our serial killers to the next step. So always arrive with the same 5 serial killers. If you're thinking about them, I need to be thinking about them, and that history is key. That history and that picture that you can help me paint in the emergency department guides my therapy. Diaphoresis, if I don't see it but you do, that risk level for me is actually climbing the ladder. Vital signs are always vital. We have to account for hypoxia and ambulatory hypoxia. We have to account for tachycardia and hypotension for sure. The 12 lead is going to be quick for us, just like it's quick for you. Our exam is underplayed a lot of times, but pulses, I believe pulses and skin are absolutely critical components to deciding what to do with these folks. Breath sounds, calves, neuro exam, to Dr. DePasquale's point with thoracic dissection, chest pain plus anything else, especially neuro findings. If that dissection dissects the cerebral blood supply, you're going to have really bad chest and back pain and facial droop or arm weakness, and that's a dissection 7 days a week. Don't forget our risk factors. What are our PE risk factors? Think about hormones, think about recent hospitalizations, postpartum patients with a history of DVT or PE. And those same risk factors apply to thoracic dissection with stimulant use and severe untreated hypertension, pneumothorax, asthma, and COPD history. Remember that our historical features and what medical problems you've had in the past are definitely going to drive and guide our diagnosis and our workup in the ED. So as always, thanks for joining us. Please leave us a like or review wherever you listen or wherever you watch on YouTube. If you have questions, email us podcast@mchd-tx.org. We appreciate y'all watching and listening. We'll be back again with a new episode soon. We'll work on the next 30-minute serial killer series and maybe hash out shortness of breath or abdominal pain next and go from there. Have a great day.